Welcome to the Menopause and Cancer podcast, where we speak with cancer patients, survivors, and incredible experts to help us find solutions to our symptoms and ideas to improve our health. My name is Dani, and today I am joined by a fantastic group of people from our community and a fantastic expert. If you are taking endocrine therapy, or if you're about to start to take endocrine therapy, medications like tamoxifen or aromatase inhibitors, then this episode is for you. You may be wondering, what are the real benefits of this medication for you? Maybe you're already struggling with some of the menopausal side effects that come with these medications, or maybe you're unsure about how much longer you can keep going the way you are. Please know you're not alone. Dr. Claire Macaulay is a fantastic breast cancer oncologist. She works in a really busy NHS clinic in Scotland. She's also a certified sex coach, and she really understands that we are three-dimensional human beings and how we make difficult treatment decisions. So in today's episode, you will learn how oncologists work out your individual benefit from endocrine therapy. We also look at the PREDICT tool and how it has changed over time, that there are different versions now and what that might mean for you. We also talk about why decisions aren't always just about stats and survival alone. They're also about quality of life. And Claire really explains really beautifully how so many people make different decisions and what their rationale, what they're basing their decisions on. And we have so many people from our community sharing their stories and also giving their feedback at the end of the session. This is a really powerful session. I'm so glad you're here to learn. Oh, and at the beginning of the conversation, I also talk about a survey which I put into the chat box for people who joined the live webinar. But I'm also going to put this really important survey into the show notes here. So if you're listening, if you're watching, please click the show notes. We want to hear your voices and your experiences so that together we can influence not just research, but really how we do menopause and cancer survivorship for the generations to come. So have your say. Dr. Claire Macaulay has been with us before, multiple times. Thank you for your time, Claire. Claire, every time I see you, you look more beautiful. Can I just say, you look radiant.
I'm just back from my holidays, Dani. That's why. Just back from my holidays yesterday. So that will be why I'm looking refreshed.
That's great. Did you have a lovely time?
I had a lovely time. Thank you. Yes, I did.
That's great. Some people who are here today may have been on a workshop with you before. For those that haven't been on a workshop before, would you introduce yourself a little bit to them, please?
Of course. Thank you, Dani. So it's lovely to be with you today, everybody. My name is Claire Macaulay. I'm a breast oncologist and I work in Glasgow. I work at the Beatson, which is the big cancer centre for the west of Scotland. And my particular area of interest that took me in a whole different direction was around what happens to people after. After their immediate treatment, where they've had their surgery and maybe their chemotherapy, their radiotherapy, whatever happens to them afterwards. And people coming back with all sorts of life-altering difficulties, but they're getting on with it because they should be getting over it. They should be moving on. Their families are all, oh, thank heavens, that's done and dusted, and I'm supposed to be back to normal. And coming back and actually finding psychologically that at the point where they leave oncological services, if you like, and go back to their real lives, that's actually when this problems really, not problems, but the whole experience starts to hit people. And part of the piece that I was interested in is specifically around people's relationships and their sexual experience. And I trained then as a somatic sex coach. I'm currently training as a psychosexual therapist, focusing on menopause and sex and sexuality and sexual expression. And of course, my breast cancer patients, I was making them deliberately menopausal or extra menopausal with the treatment that I was giving them. And that's where all of this kind of started. And then it spread out to dealing with people with menopause more generally and the impact that that has on their sexual expression and their relationships. So I work part-time in the NHS, treating people with breast cancer, and I work part-time as a sex and relationship therapist, helping people to navigate some of the longer-term issues.
I'd love to have a whole session with you on that as well. And we have spoken about sexual health and intimacy before, but I don't think we can ever talk about it enough. And so I'd love to maybe book a session in for that.
Absolutely.
today's conversation, we labeled the workshop as how to navigate tamoxifen and aromatase inhibitors. A few of the lovely faces we've seen, I kind of know people have been struggling and on that journey and path themselves for a long time. But before I get to ask you loads of lovely questions, I want to say to all of you who are attending here today, there's over 65 of us on the call. Thank you for your donation. So all of you have donated a little bit of money to be here today. And Phoebe just told me you've donated over £500 worth of money, which is thank you so much. It's really great. And with that money, we can now put someone in our community forward for a whole free menopause specialist appointment with a free follow-up. So as you know, Claire, as part of our services, we can give away an appointment every single week. So all of you have made that happen because you wanted to see and come and join Dr. Claire Macaulay. But thank you for that support, because it does mean a lot to us. And it's great if we can then not just talk about the information, but also provide services. I'm really passionate about also providing the services that come with more awareness and more information. So thank you, everyone. I will also share a survey with you together with a couple of hospitals and doctors. We've put a new survey out. Maybe you want to share it with your patients, Claire, and I'm really happy to share all of the survey results with you, should that ever be helpful, just to truly understand how we can further research. And I think if we get a little bit of data together of the experience for cancer patients and the menopause, then we can start to maybe influence research, which is desperately needed, isn't it?
Well, Dani, I mean, you and I did a survey together previously, didn't we, about sex and menopause and experiences and relationship experiences and what people have been told and what they hadn't been told. And I've taken all of that data and presented it at a number of national meetings in terms of the kind of patient voice of this is what is happening to people afterwards, and we're not talking to them about it. And where do they then go in terms
That's
of having that experience? And you know, if we as healthcare professionals are not bringing up the issues that can arise in people's lives post, other than saying you might get a few menopausal symptoms, and not really being able to understand the impact of that, then health professionals don't understand the importance of having conversations on what needs to happen. So people are willing to fill in surveys and give us feedback. Certainly people like me will take that on and make sure that, you know, oncologists all over the land know what the impact is.
Thank you. I've dropped their form for the survey into the chat, everyone. It would be great if you could open it so that you can get to it later. I think when you present to your colleagues, it's so good to have some numbers, isn't it? It's no good to say, I've had these patients in my career, they've been struggling. But if we can show maybe nationwide or globally what the issues are and how we could then start to provide better services for everyone, that always makes such a big difference. We need some data, so fill in the survey, everyone. Before we get into the troubleshooting, which you're so great at, can we also talk a little bit about these treatments that make us menopausal? People come to me and our community because they're struggling, because they found they haven't had maybe the help they needed elsewhere. But Claire, there must be a big amount of people who are not struggling. Can we talk about that a little bit before we do the troubleshooting?
I think that's a really important thing to say, is that, you know, when people come to something like this or they're seeking information, it's usually because they have a problem. But there are a proportion of people who are not having problems. So we are a self-selected group, an important group, but that doesn't necessarily mean if you're on the call today and this is a treatment that you're about to start, or is being suggested to you and you're mulling it over, that's not to say that it's a guarantee that everything that we talk about today is going to be something that you're going to get. So we do know, however, that the research tells us that about 50% of people, so that's half of everyone who starts one of these kinds of treatments, will not complete it to its full term, whatever that is, whether it's 5 years, 10 years, whatever that is, that we know that half of people will not get to the end. Now, there's different reasons for that. But the vast majority of that is to do with side effects. So the experience that people are having on the medication, that they feel better off it. So it makes perfect sense. If I feel worse on this medicine than I would off it, and I'm now 2 or 3 years down the line from my kind of initial diagnosis and I'm getting back into my life, I might go, yeah, no, you're all right. So we do know that it is a significant problem for about half of people. But that means there are half of people, I mean, there's people I phone and they're, you know, well, when I maybe do their post-radiotherapy review, they've maybe been on the treatment maybe 12 weeks, 16 weeks, something like that. who are having no problems at all. So that is also possible. But let's accept that we're likely to be a self-selected group here of people who are having difficulties, and that's
And recently, so it's good to let's go and look at a few more numbers to do with cancer treatments that put us into the menopause. So about half of people don't stay on treatments like tamoxifen, aromatase inhibitors, because of a lot of them are menopausal side effects. The other day I did a workshop and a lady moved out the door a little bit early, and I said, I hope you're okay. Did you come what you needed for? And she said, do you know what? I had tamoxifen sat in my bedside table and I didn't dare to start taking it. I was so scared. I wasn't going to take it. And I said, oh, okay. I never like it when people leave, and I don't know whether they gained from the workshop what they needed to come for. And she said, but I'm fine. I'm done it. I'm starting tonight. And so for her to hear experiences of others was just, she probably just needed a little bit more information to start or give the drug a go with confidence. Do you have a proportion of people that never start their treatment in the
Well, we
first
don't,
place?
it's harder to do that because people don't tell us. That's the thing, is that we're ultimately, and that's why these kind of surveys and data and real world data is important, because I wouldn't know. That woman could be going away, she could be picking up prescriptions and still not taking it. So we don't actually necessarily know exactly those kind of numbers. We know how many don't get to the end, but is that people who get to the end who never started, or who started and got problems? So it can be difficult to know that information, because we know that even although people might not be taking it, they might still be fulfilling the prescription. So if we then go and try to look at data, the way we would do that in a research sense is we would go to general practice data, which is usually your GP that's prescribing this, and we would say how many patients have got this, and how people might still be filling their prescriptions and still not taking it. So, but we do know that there's a proportion don't start, and that might be an intentional decision with their healthcare providers at the beginning. No, thank you, I don't want that. Or it might be people who go along with, or feel overwhelmed or bombarded, or get home and start reading about things, or doctor Googling or whatever else, and feel, as that lady did, too scared to start. And what I often say to people in that situation is, this is not a conveyor belt that you can't get off. If you were to start this process and have some problems, one, you can stop it. So nobody's going to make you take it forever. Two, they might settle over time, because quite often they do. Or three, there might be things that we can do to help you. If you develop problems, there's lots of ways of being able to manage some of those things. So I really, that kind of fear at the beginning thing, I think, is often driven by a general not enough understanding of what that person is fearful of, and being able to validate and understand what their fear is, and also being able to provide them with things that might make them feel better about stuff. So all of those things are important.
And actually, we've got Sue here who said, I haven't started. I'm so scared of the possible side effects. So, Sue, stick around to the end just to see whether maybe the workshop today provided you maybe with an encouragement to seek more help from your doctors, or maybe you just had a missing link. Because I think, with more awareness, and we've raised so much awareness, we've had over 300,000 people download the podcast, for example. More people are going to hear the stories of other people suffering and not doing well. And so I am really understanding that there might then be a bigger proportion of people more worried. So I think we have to be very action focused and get really good, decent information to people so that they have the information they need quicker to make informed decisions.
And we need to acknowledge that that fear is real. And often what I find happens is that because the starting the hormone treatment, depending on whether you're just having hormone treatment or whether you've been through chemotherapy and radiotherapy and everything else, the starting the hormone treatment also comes at the same point where you're being let go. So those two things are happening at the same time. And often what I think is happening is that the accumulated fear and worry that is sort of suppressed to a certain degree when you're on the treadmill of the next chemotherapy cycle or the next bit of radiotherapy, is that coincides at the same time. So all of that fear and the realization of what's happened to you and the existential crises that come around, is this going to come back, and fear of recurrence, that all collides with, and almost the starting the hormone treatment becomes the hanger on which I can put all of those feelings. And then all of a sudden the hormone treatment becomes the big thing. So it makes perfect sense why there would be a lot of fear and a lot of, and at the same time, your family are like, oh, thank heaven that's on, we'll just get on with life. we
Yeah.
can move on now, when of course you emotionally are not ready for that. And so this very fragile time coincides with starting the hormone treatment, and therefore the hormone treatment becomes an easy thing to put our fear and our worry and our concerns into, when actually it might be all of the other stuff that's built up to that point.
Thank you, Claire. And on the other end of the spectrum, so we've got some people that never started treatment for whatever reasons. It might be an informed choice or worry. People starting and doing okay and finishing their course, people finishing their course early. And then you've got the people that are having to stop their course because of side effects becoming
Yeah.
too much, because they feel so much pain in their body,
Yeah.
because their mental health is in such a different space. They cannot function to how they used to function. And then it's almost the mental aspect of that. We must talk about that, because these feelings of real, it's agony. They're devastated that they're feeling like this. They're very scared because you're going against medical advice.
Yeah.
You don't want to do anything. You want to do everything you can to keep cancer at bay. So it feels awful that you can't maybe tolerate. And many people have tried lots of things. And it is those emotions of guilt and maybe shame. And
Yeah.
how do I communicate that with my family? There's a lot going on, isn't it? And I find that people often have to make these decisions themselves. Even if you get to speak to you, it's a lot of mulling that we have to
Yeah.
do, and it's a long process of months and years sometimes
Yeah.
to come to that decision.
There's a lot of, what I notice is there's a lot of rumination happens, and sometimes quite
Yeah.
harmful internal rumination of, you know, if I don't do this, almost a uncertainty, if I don't do this, my cancer will come back, which of course, all of these treatments, as we've discussed before, Dani, and we'll talk about, are simply about reducing risk.
Mm,
If you reduce your risk by this much,
mm,
but your quality of life is impacted by this much, then this risk might not be worth it. So
mm,
there's all sorts of weighings up that have to happen. And of course, when our minds get left to ourselves and the rumination and the fear and all the rest of it gets going, that's a really difficult place to be. And it can feel really lonely and really isolating of, I am the only person who can make this decision.
mm,
And sometimes I think it's really helpful to be able to, if it's your healthcare professional or your breast care nurse or someone else, to actually realize that all of these things are a choice, and they are all a trade-off. So nothing comes for free. You know, the medication will come with some variation of side effects that you will experience to some lesser degree. The side effects might be worth it if your payoff is your cancer not coming back, for whatever the level of risk that might be for you. But all of that internal machinations can be really, really distressing. And I imagine, it feels very lonely and very isolating and very scary, I imagine. And all of that is really happening. It's real.
And so this one person, and if you're putting questions into the chat, I will read them out at the end of the session, promise. This one person said her predict score is only 1% benefit, but I love Claire's analogy of how you explained the emotional aspect of it. Can we talk about the benefits of those treatments? Do you want to sum the treatments up? I'm going to run a little poll to ask people whether they want you to show them how the predict tool works, because I think there have been updates and I get a lot of messages of people saying, is it predict 2 or 3 or whatever? And I have no idea what they're talking about. So I'll ask people in the poll whether they want you to show it to them or whether talking about it is enough. But give us an overview. And I'm assuming here, but please put in the chat, I'm assuming the majority of you has had breast cancer. There might be some gynae cancer patients in here today who've also been put onto some of these endocrine therapies. But let's talk about the endocrine therapies. And sometimes there's not much between the two either. So let's talk about that a little bit, please.
So we're talking about hormone therapies in general, but of course there are two main camps of those things. There are tamoxifen, which works in one kind of way, and there are the aromatase inhibitors, which are letrozole and astrazole, exemestane. They're the kind of three that we tend to use in the UK. And they're quite different drugs in terms of the way that they work, but we're going to talk about them combined today, because to get into the subtleties of the difference between them doesn't really matter when we're talking about the side effect profile, because the side effect profile can be very similar between the two of them. So we're talking about these drugs because we know from giant studies of thousands of women that giving people hormone suppressing treatments reduces the risk of their breast cancer coming back. But that risk is individual. So one person on a hormone treatment might have a 6% reduction in risk of their breast cancer coming back. And we'll talk about what those numbers mean. Versus someone else, like in the comments, who's got a 1% chance. So we'll talk about what that actually means so that we can start to put the risk in context. What that means is, and most of these numbers mean in 10 years' time. Okay, so if I take 100 people with the same type, same grade, same number of nodes, same type of breast cancer, if I give 100 people letrozole, let's say, 6 of them, if you have a 6% advantage, 6 of them will be additionally alive in 10 years' time. Now, 60% of them might have been alive anyway without having the treatment. So it's not that this is your only, it's reducing your risk from whatever your underlying risk might be. And that's what PREDICT helps us to do. PREDICT helps us to figure out a specific situation, but what the risk might be. So what it means is I have to give, if you have a 6% benefit from letrozole, I have to give 100 people the medicine for 6 of them, 6%, to be additionally alive because of it. But that means that there's 94 people taking the medicine who may be having side effects and may be having problems and all the rest of it, who are not getting any benefit from it at all.
You just don't know who you are. You just don't know, because it's
The
always
difficulty is I don't know. Exactly. You don't know, and I don't know whether you are one of those people or not. And of course, it's all based on statistics. So it's all statistical risk. Now, somebody might say, gosh, 6 additional people, 6%, the chances of me being alive, additional, I'm adding 6% chance to my underlying chance of being alive. That's really worth it to me. Somebody who's got a 1% chance might say, these side effects I'm having are not worth a 1% additional chance of being alive in 10 years' time. And that's a very individual decision. And I've had people who've come in who've taken chemotherapy at a 5% risk and said a 6% risk of hormones isn't worth it to them. I've had other people come in and say, I want to do everything I possibly can. This is horrific, but I'm willing for this additional 1%. And to a certain degree, we have to be able to understand your individual risk profile, your risk appetite, what is worth it to you. And that's what the conversation needs to hang around. Because if somebody came to me with a 1% risk benefit, like the person in the chat, and said, I can't sleep, I'm grumpy all the time, I can't do my job, I'm having hot flushes, I can't have sex because I've got vaginal dryness, I would be saying, is that worth it? Is that 1% chance, additional benefit of being alive over your 89% chance of being alive anyway, is the difference between 89% chance and 90% chance worth it for you? And some people will say yes, and some people will say no. And that's why it needs to be a very individual decision.
Do some people have as big a benefit as 50% survival benefit on these treatments? No. Okay, so we're
probably talking for hormone therapies, depending on how, depending on lots of different factors, which is what we take into account, as you well know, in terms of your individual risk of your breast cancer coming back, the grade of your cancer, the size it is, the number of nodes involved, all of those kind of things. You know, the maximum benefit you're likely to get from a hormone treatment is somewhere between 9 to 10% maximally, if you were getting the absolute maximum benefit from it. But a lot of people, because we detect people through screening and they have small cancers and they don't have nodes involved and all the rest of it, you might be talking in the order of 1 to 4%, something like that, additional benefit. So I think being able to understand what that means for you and you being able to weigh up whether it's worth it based on the experience that you're having on the medicine.
And of course, we can't always have all of those conversations with our patients, right? We had a beautiful breast oncologist at our event in Birmingham, and she came as a patient. She had also had a breast cancer diagnosis. And at one point she said, look, I've just got to defend oncologists here. She was lovely. She was so lovely. And we said, please tell us what is going on for you in your job. And she said, sometimes I've got 15 minutes and I need to talk about all those things and I need to consent people on all of their treatment protocols. And at the end of the 15 minutes, I might prescribe them tamoxifen or an aromatase inhibitor. I don't even have to consent them for it. And it is literally the last bit of that 15 minutes, and I'm running out of time. And we really all really understood where she was coming from, because she's trying to do her best, but it's very difficult with the resources you have. And so that's why so many people come and find us then and say, no one talked me through my individual risks. And so it's an afterthought of that conversation often.
Yeah. And I think that's true. And I think as well, there is so much information. I mean, if somebody comes to me for their first consultation, so we know that they've got a breast cancer, they've had their, let's say they've had their surgery, they're coming to talk about adjuvant treatments, and we're talking about chemotherapy and maybe even immunotherapy and radiotherapy and hormone treatment and bisphosphonates for their bones. You know, it's way too much information to be able to hold in one go. And so I tend to drip feed that information when I can. We have the conversation at the beginning and say, look, we're going to talk about all of these things, but there is no way you can possibly hold on to all of that just now. So we're going to talk about this. So we're going to talk about chemotherapy and we're going to talk about this, and we're just going to take that one cycle at a time. And then when we get to the end, coming towards the end of that, then we'll talk about your radiotherapy and your hormones at that point, because trying to do it all, it's just totally overwhelming.
Too much,
Same
yeah.
because she's just had a life-altering diagnosis. So, you know, don't be scared to ask questions way into the process, because we understand that there's no way you can possibly have remembered all of that information. And, you know, if you're not sure, then ask. There are time restraints. Let's not be, you know, let's not be blind to the fact that that's difficult. But the questions that you ask are often the most pressing thing for you. So we can spend the time on the thing that's the most pressing for you.
So 53 people out of 63 want you to share and talk about that predict, please. And for the 10 of you who said no, I'm sorry, this is a repetition for you. You may have done your research, you may have had the conversation with your own doctor just recently. Can we talk about that there is a new version of this as well?
So let me share my screen and I'll show you what it is, first of all. And those who said no might not even know what it is. So that's helpful. Or you may know completely what it is. So can you see my screen and see what I'm sharing? So this is an algorithmic tool. And what it's based on a research group from Cambridge who take data when we follow people over time to try to give us an idea of, can we predict when somebody is diagnosed what is likely to happen to them further down the line? Because as you well know, Dani, and people here will know, you know, breast cancer, if it's going to come back, can take a very long time to do so. You know, I have people who come, I've got a patient now who was diagnosed with secondaries 22 years after their first diagnosis. Some people, it might come back immediately, and there can be anything in the span in between that. So we're using the predict score to give us an idea about what might happen in the future. And we're using the predict score based on huge data sets, thousands and thousands and thousands of women who've been through the experience, to try to see, will chemotherapy help? What's the additional benefit of chemotherapy? What's the additional benefit of radiotherapy? What's the additional benefit of hormones? What's the additional benefit of bisphosphonates? So that's what the tool is doing. It's basically giving us an idea statistically, not for you specifically, but statistically for people like you in your situation, about what will happen. Now, you will see on here, it says that there is a newer version of the tool. Now, the difficulty is at the present time, certainly where I am working, we are still using the previous version of Predict for reasons that are not because there's anything wrong with the new version, but it requires some validation and some experience over time, because the new algorithm, based on more recent data, also needs to have a little bit of bedding in time for us to be comfortable that the numbers that we're giving people are correct. So if you use the new version, you will often get data which shows that people do better. Now, that is probably true, because if you think about it, when we do these data sets, if we're looking at what happens to people over 20 years, then the people who are today 20 years got their treatment 20 years ago, and the treatment 20 years ago was very different to the treatment that you might get today. So there's always a lag in all of these things, because we can only ever do this in retrospect. We can only ever go back and see what's happened to people up to this point. So there is a new data set. In general terms, in the centre that I work, for the time being, we're using the previous data set. I think that probably is under-reporting the survival. So I think the newer version shows that people live longer and do better because of newer treatments. But for now, in our centre, that's what we're doing. So it's helpful, I think, sometimes if people are doing this themselves, because you can get this, it's online. You just go to Predict Breast and you'll find it for yourself. You can put your own details in. You can use both and see, and they're not going to be wildly different, but it might be the difference between 1% and 2%. Now that's 100% difference. Going from 1 to 2 is 100% difference in overall survival, but it's actually only the difference between being 1% or 2%, 1 or 2 people in 10 years' time. So let's just show people, well, should we just show people, Dani, what it is? If you've seen it before, basically what you do is you put in your details, and it goes through the things that you can get this information. If you don't know it yourself, you'll be able to get it either from letters that have been sent to your GP, or you can ask your oncologist or your breast surgeon if you've never actually seen an oncologist. And you go through and you plug it in. So I'll just pick some random ones, Dani, and we'll put it in and we'll see. So this DCIS, that's the precancerous part before cancer. If you've only got DCIS or LCIS being lobular carcinoma in situ, then you would answer yes to this question. But for the purposes of this, we're going to assume that somebody's got an actual cancer carcinoma. So let's say that you're 42 when you're diagnosed. Now, if we think about age, it makes a massive difference whether you're 42 or whether you're 82 when you're diagnosed, because you have an additional 40 years of life to live. And also, if you're 82, you're far more likely to die of something else. So again, the age matters in terms of the amount of time that you're likely to live. In general terms, if you hadn't had your breast cancer diagnosis. But for the purpose of this, we'll put in somebody who's 42. And we'll say that they're not postmenopausal, okay? And we'll say that they're estrogen receptor positive, because we're talking today about aromatase inhibitors. And of course, aromatase inhibitors and tamoxifen are only for people who've got an estrogen sensitive cancer. If you were estrogen negative here, then we wouldn't be talking about this for you in any event, okay? And we'll say for the purpose of this that we're HER2 negative. There will be some people here who are HER2 positive, but for the purposes of the fact that we're talking about hormone treatment, we'll say that you're HER2 negative for just now. And we'll say unknown for Ki-67, because a lot of places don't do a Ki-67 score. So it might be that your centre wouldn't do that in any event. So we'll leave that off. So let's say that you've got an invasive tumour size. We'll start for this and we'll say 15 millimetres. So we'll make this somebody who's got a relatively early stage cancer. So they're 42, they're ER positive, they get a 15 millimetre cancer, so a 1.5 centimetre cancer. And we'll say that they've got a grade 1 tumour. Okay, so again, cancers are graded on their aggressiveness, from grade 1 being the most that look like normal breast cells, to grade 3, which look more aggressive and look mutated away from looking like normal breast cells. But we'll say it's a grade 1, and we'll say that you found the lump yourself, so you've got symptoms, and we'll say that you've got no nodes positive. Okay, so we'll then go into here and we'll say, what are the benefits of having chemotherapy? And what are the benefits of having endocrine therapy for 10 years? Okay, and we'll say no to this piece about receiving. That's a different thing. So if we come to here, sometimes I think the easiest way to do this is to do it with these little circles. So what that means is, if you are this person, you're 42, you've got a 15 millimetre grade 1 cancer with no nodes and you're ER positive. If you've had surgery, in 10 years' time, 94 people out of 100 who are like you will be alive just having had their surgery on their own. Okay, so that's really important to understand, is that you have a 94% chance of being alive and well in 10 years' time, if this was you. You've had your surgery. What this also shows is, if we look at these grey ones, 2 people will have died of something else, been hit by a bus, had a heart attack, whatever. 2 people will have died from something else. And 2 people out of 100 will have died from breast cancer. Okay, so you've got a 2% chance. If this is you, your chances of dying of breast cancer in the next 10 years are 2%, 2 in every 100 women like you. And if we look at the treatments that you might be offered, only 1 additional person would be alive if we gave them chemotherapy. That's this orange one. So this person In this circumstance, we'll leave aside whether you have genetic testing or not of your cancer. That's a conversation for another day. But one person would be additionally alive if we gave all of these people chemotherapy. So this person is not going to be routinely in the UK offered chemotherapy in this circumstance. Because a 1% survival advantage from chemotherapy when there is a 1% chance of killing you with chemotherapy isn't a good swap. So this person wouldn't be offered chemotherapy. We normally suggest that people have chemotherapy if their survival advantage is likely to be 3% or more. If you fall in the middle gap there of somewhere around 2 to 4%, you might have genetic testing to see whether you're a high risk or a low risk. But for this person, chemotherapy is not going to be offered to them because we don't think the benefits of it are worth it. So if we come to the blue one, there is 1% survival advantage with your hormone treatment. So if you are this person, if you're sitting thinking, oh, that actually pretty much suggests that I am who I am, that 1% survival advantage means I have to give 100 people like you tamoxifen, likely in this case. I might give you Prostat and exemestane, which is to switch off your ovaries, but you're premenopausal, I'm likely to give you tamoxifen. You're likely to have a 1% survival advantage from that tamoxifen. So if that tamoxifen makes you feel terrible, gives you brain fog, struggling with work, all the rest of it, all the other things, you might decide that that's not worth it.
Claire, can I ask you
Of course.
something right there? So when you said everyone currently with an hormone-sensitive breast cancer is then offered endocrine therapy, that means even if it's just one extra person out of the 100, everyone currently in the world walks away with either a prescription of tamoxifen or an aromatase inhibitors, and they have the ovary switched off as well, right? There are lots and lots of messages here in the comments saying, I worry about the damage my endocrine therapy is doing to my body. I can't sleep. My bones and muscles hurt. I've round the clock severe hot flushes and my mental health has declined hugely. But I feel as though I have to carry on with the meds. What are the statistics on long-term health implications outside of cancer as a result of the medication? And about the same messages is coming quite a few times of people saying, I've gained so much weight. I think my weight gain is now a much bigger driver to my cancer coming back than the benefit of my endocrine therapy, but no one can give me any advice on what to do.
Absolutely.
Claire, so here you've said very particularly, you would not give this person chemotherapy because the risks of chemotherapy may outweigh the benefits of chemotherapy, and you've made that decision. Why don't you make that decision on endocrine therapy when there are also risks to endocrine therapy?
Absolutely. Because the truth is, we don't know, we haven't quantified those risks. So if you say to me, what is the risk to my bone health? What is the risk? Then actually we don't have the same kind of data and we don't think about it in the same sort of way that we think about chemotherapy. Because we can see that chemotherapy are immediately dangerous drugs. So I might kill you today with chemotherapy. Does that make sense?
Yeah.
So the truth is, because we're not really thinking about it in that way. Some of us we are starting to, and actually the next version of Predict, the version 2, also takes into account the potential harms. So that the data is there, but we're just haven't quite caught up in the same sort of way. But the next version of Predict gives some kind of indication of harm. The difficulty is that we don't know. I can't tell, in the same way that I can't tell you which one of this 1% will be. I can't tell whether that 1% will get an osteoporotic fracture and break their hip and die when they're 65 of some complication of a hip fracture. That's less likely with tamoxifen than it is with the aromatase inhibitors. But if this woman was older and she was postmenopausal. So the truth is that we don't really know. But absolutely. So for example, if this person is obese, for example, let's say they're 42, they come with their breast cancer and their BMI is 35. Their biggest reduction in terms of reducing the risk of their breast cancer coming back comes from losing weight, not from giving them tamoxifen. So it's all of those things that need to be borne, and we're not at a place yet where we can be clear about a lot of that.
Someone just said, I'm on tamoxifen. I've gained so much weight in my first month alone. What am I going to do carrying on? So there is all of the uncertainty. I understand we don't have big data and surveys to say what are the negative implications of endocrine therapy. And that is also why we need all of you to fill in the survey so that we can create that research and understand. So we have side effects that impact us, like, for example, sexual health and loss of libido. And one could argue they're not a threat to your life. And then we have side effects that might be high cholesterol, that
Mhm.
might be bones, that
Mhm.
might be feelings of such low mood that
Yeah.
people talk about suicide that are a threat to our life. Are you saying we just need to start to quantify exactly what those are and do more research? Because obviously the symptoms can be so
Absolutely wide
broad,
varied.
isn't it? They're
And
so broad,
there are
yeah.
some genuine ones. If we think about tamoxifen, for example, the increased risk of endometrial cancer, for example. So all of those things need, there are genuine, demonstrable, statistically known issues which come with some of the treatments that can all of themselves be life-threatening, or at least need to be managed if they arise. So absolutely, you can see if somebody is sitting in this situation and say, well, you wouldn't have ordered me chemotherapy because the risk is too great, the benefits don't weigh out. But tell me what the benefits and risks of a 1% additional advantage of endocrine therapy is in terms of my health, not in terms of the symptoms I might get. That's a more difficult conversation to have because we do know, but I get to some degree in the ether, but actually it's not been brought together. And Predict Point 2.0 attempts to do some of that.
Mm, mm, mm. Mm. Before we talk more about what we can do as well, and I want to read out a lot of the questions, someone just said my healthcare team has disappeared after my initial cancer treatment. I think people would like to go through this Predict with a healthcare professional rather than trying and doing it on their own. Who can we contact? Is it a GP that can also do that with us, or do we need to connect back to cancer services?
Usually the best person to go to is whoever your breast cancer nurse is, because they are the person who either can do this with you and sit down and go through it, and or look at with you the symptoms that you're experiencing and the experience that you're having and what might be helpful, and or get you back in touch with whomever it is within the team, be it the surgeon or the oncologist or whoever it is that can help you. So I usually tell people to go back to their breast cancer nurse in the first instance, because they're the kind of gateway, if you like,
Mm, mm.
getting to the right person.
And Claire, someone I think was trying to do this, saying Predict says hormone therapy does matter by a few percent. But it doesn't say does it matter if it's tamoxifen or aromatase
Yeah,
inhibitor. And
yeah.
what we've heard in our community quite a few times is that people say, I don't know why I'm on an aromatase inhibitor and they're switching off my ovaries. I think a few years ago I would have been treated with tamoxifen. I don't know what they mean. Has there been a trend in prescribing these medications, or what's the difference in benefit, really?
Yeah, it depends, and that can be very individual, and that can be quite clinician specific as well in terms of um, if you had, so let me think about what I would do there. If you had, so let's change this woman and make her more high risk, and then that will give us something to hang that off. So let's remain that she's 42, and well, actually, we'll make her older, we'll make her postmenopausal. That might be easier. Let's say she's 56 and she's postmenopausal and she's ER positive, and we'll leave her HER2 negative, and we'll say that she's got a much bigger tumor. So let's say she's got a 55 millimeter tumor and it's grade 3, and that it was detected by screening, and let's say that she's got 2 positive nodes. Okay, so that again is a fairly standard way of being. And then let's see what the charts look like. Okay, in fact, let's not make that. I forgot that Predict has an issue with people who are over 50 centimeters. So let's make it like that. So let's say at 10 years, this is the situation that we're at. Okay, so if you are this woman, and we're putting these details in, less than half of people will survive just by having surgery on their own. So you can see that these numbers look very, very different to the first woman, which is why being a patient with breast cancer means absolutely nothing. It means, what is your breast cancer? Because you can see all I've done is I've changed her age, I've made her tumor a bit bigger, and she's got some nodes positive. She's still a woman with breast cancer, but you can see that these numbers look really very different. So because she's a little bit older, there are 6 people who will die of something else as opposed to 2 people who will die of something else because she's already older. You can see that the number of people who will survive just with surgery alone is significantly less. So less than half of people, which is why these are the people who we want to get with chemotherapy, because you can see if I give this woman chemotherapy, she has an 11% survival advantage. That means 11 additional people will be alive. If I give all 100, 11 of them will be additionally alive. And you can see that she's got a 12% survival advantage from her hormone treatment. That's probably at the top end, as I said, somewhere between 9 and 11. This is a wee bit more. The newer version would probably move it down a little bit. So to give you an idea, this is a totally different set of circumstances. If somebody comes to me and says, I've got side effects, it's a totally different way of thinking about it, of saying, actually, your biggest overall benefit of anything that you will have done is your hormone treatment. And therefore, we need to talk about how we keep you on that treatment. And I'm going to spend much more time and effort and trying things and persuasive powers to keep this woman on treatment than I would the other woman.
Yeah.
Does that make
And
sense?
and totally, because I think when we know, I think not knowing is what drives people a bit crazy. And so then everyone is just a bit like running around, just really not knowing where to turn to and what to do next. And I think sometimes people just don't know how great their benefit is. So that could help them actually say, okay, I have these side effects, but my benefit is X, and that is great. And so I'm happy to have those side effects, or not happy, but like I'm happy to endure them. And sometimes they think their benefit is so small, they didn't know that it was so small. They've endured horrible side effects. And there's a lovely lady here. She said, this is the first time since my diagnosis in 2022, Claire, that I've ever had this predict explained to me. I only have a 1.1 to 1.4 advantage of taking hormone blockers. This gives me so much to think about right now. I feel quite emotional even. So thank you so much, Claire. And I think when we talk about all of this, we must always understand it is quite difficult to talk about that as well. We're not always ready to see those little numbers. It can be really scary as well, can't
I
it?
think that's really, really important. So what I do before I do any of this with patients, I say, do you want to know?
Yeah.
Because if this is you and it had never occurred to you that you'll see, even with all of that treatment, there is a 27% chance that you'll be dead. Do you want to know that or not? And that's a really, really important part of this process of making the decisions, is that this might be terrifying for somebody who hadn't contemplated what
Mm.
we're actually talking about.
Yeah.
That doesn't mean that you're going to be one of the 27, but it means that 27 people in your circumstance are going to be dead in 10 years' time, or more of them if you take in the 6 have died of something else. So, there's a lot of, when we're talking about the fear and the managing and all the rest of it, there's a discussion needs to be had before we dive into all of this to make sure that people are emotionally ready for what this means.
Mm. Absolutely, Claire. Absolutely. And, on the one hand side, I'm very much advocating for getting so much information out that people can make informed decisions, especially how to help with all of those symptoms. But also, I know so much that we don't always make decisions based on just evidence and facts alone. And so for some people, they don't want to know that they take the drugs. They just don't want to know all of this because it's too much. And that's okay, isn't it? And
That's a
that's
perfectly
totally,
legitimate
perfectly okay.
way to approach this. And I think there's a really important part in some of this. So a lot of the other work that I do around managing and helping people to deal with and come to decisions about things is that there's this beautiful quote, which is that fear doesn't respond to data. I can give you all of this information in the world. It doesn't touch
No,
your fear until
no,
I know what that fear is,
no.
and I can validate that that fear is absolutely justifiable and understandable.
Yeah,
And we can deal with the fear, and then we will get to the data. When
yeah,
you're in that fear cycle, none of this is going to sink into your frontal lobes because
no,
you're run by fear. And
no.
so understanding and judging and asking and being clear about when people are ready to have this information. And sometimes they're not ready at the beginning.
Mm,
And so, and I think sometimes what happens as healthcare professionals is that we forget that. We think we've told you it all at the beginning somehow, and that somehow it should stick and that you should understand.
mm,
But that's not really how it works, and you need to be ready. So if
mm,
anyone is sitting here who is thinking, so I'm going to go and put stuff in my predicts, that's fine. But you need to know that you're supported and that you're emotionally resourced to
Mm.
deal with whatever the
Yeah.
numbers show.
Yeah. And I like what you say about the fear, because I had as I have shared before, I had a non-hormonal triple negative breast cancer. It was grade 3, stage 1. And I was told by my oncologist that if I make it to 2 years post-active cancer treatment, that would be great. And I would reduce my risks of a recurrence by a chunk. And I was also told that if I make it to 5 years, that would be also really great. So I had milestones there, but my fear of recurrence did not align with that. And I had other things happen around me, and family members, and an aunt dying of ovarian cancer, and all sorts of things that influenced me. So my fear did not align with my oncologist statistics. And I always felt out of kilter. And I think people at home might resonate with that, because there are so many other things that influence us. And sometimes your fear might spike a long time after, because maybe a friend is going through something similar, or something else is happening in your life. And so it's wherever you're at the time.
And for me, as somebody who really believes in a kind of holistic approach to a lot of these things, living in a state of fear is not the best set of internal physiological
No,
circumstances for you to recover from the treatment that you've been in, or
no.
to reduce your risk going forward. So managing the emotional impact of all of this is really, really important. And certainly the centre that I work in, we have a fear of recurrence programme that I will
Oh,
send
amazing.
people to and say, go and do this fear of recurrence programme, because the internal physiological state that is being created, completely understandably by the fear that you're experiencing, is not the rest and digest healing set of circumstances that you want inside of your body to recover from this experience and to keep you healthy in the long term. So managing all of that, the numbers are the numbers.
Mm.
We don't treat numbers. I don't
No.
treat numbers. I treat people.
Yeah.
And in order for those people to be optimally well after their breast cancer experience, is not just about giving them medicines. It's about managing all of that so that they can flourish after breast cancer, rather than be caught in what can sometimes be a very negative
Mm.
fear-based cycle that then impacts the rest of their life. Their relationships, we know that people's relationships break down more. You're more likely to end up divorced if you've had breast cancer. You're more likely to end up in a sexless relationship, all sorts of other things that impact your quality of life more generally, that people don't relate back to
Mm.
their breast cancer diagnosis.
Mm. When we talk about how to manage tamoxifen and aromatase inhibitors, I'm going to now say to people, listen back to the beginning of the year, where with a lot of Claire's colleagues, we talked about all of your treatment options, your non-hormonal treatment options, your complementary therapies. We talked about hot flushes with lots of great doctors, because I can see we're running out of time. So what I do want to talk about is just something you've just said that was really important. You're not treating numbers, you're treating the person in front of you, Claire. And that person is more than that predict tool. So,
Yes.
okay, there was the 1% chance of chemotherapy. We won't give it to that person. We'll talk about the risks and benefits of endocrine therapy. Just this week in ASCO from America, a new updated study got released about the benefits of exercise, for example,
Yep.
and how regular exercise can reduce our risks of a cancer recurrence. Now, I've written about it, and we know the data and everything, but it's another reassuring movement towards that. How can we start quantifying that? Because I am the person at home working really hard, improving my diet. I'm trying to reduce my stress levels. I'm exercising. How can I throw that into what tool? Like, what's that tool called?
So
Danny's live after cancer
that's
survivorship.
yes,
Like, how
that's
do you,
difficult. That
you
that
know what
that
I
is that
mean?
requires its own algorithm, Dani.
Yes, yeah.
And of course, what we don't know is we don't know, because we don't know whether some of these things are additive. So we don't know if I lose weight and I exercise and I stop drinking, does that add up to more? We don't know the answers to any of those things. And I think sometimes people that's a really dissatisfying answer when I
Mm.
say to people, I don't know. And we have to try to manage what we do have and what's going to work for you, because I cannot give people a cast iron guarantee. The one question as an oncologist that people always want to know is
Yeah.
what is going to happen? And I don't know what's going to happen. But to try to think about the things that matter. And
Mm.
the things that matter are your general health and well-being. That includes your weight. and your cardiovascular health and all of those other things, if it's if you hadn't had cancer. So all of those things still apply. We know that people who do exercise live longer. We know people who maintain their weight within a normal BMI live longer, because there's other things in addition to dying of breast cancer.
Yeah.
There's dying of diabetes, or there's dying of heart disease, or there's all of the other things that your breast cancer treatment may or may not influence.
Mm,
So there's not a certainty tool, which is what everybody would like. There is a what feels good for you and feels good for your body, because
mm,
when you feel, often what I say to people is, even knowing that you are doing something can be healing of itself.
mm. Yeah.
Knowing that you are doing something that is good for your body means that you feel like you have some kind of control, when
Mm,
often, certainly at the beginning, when people are managing the shock of a diagnosis and all this, that you feel you've absolutely no control whatsoever. So
mm,
trying to look at the things that on balance make your life better or worth
mm,
it. Because the people go to the other extreme and they go on massively restrictive diets, and they,
mm,
it's all which actually impedes their quality of life,
mm,
impedes their enjoyment of life, which of
mm,
itself, pleasure is of itself healing, which is a whole other topic for another day.
mm,
But
mm,
the experience of pleasure in our body, the experience of relaxation, the experience of exercise, the experience of connection, the experience of touch, the experience of sex, all of those kind of things are healing for
mm,
our body. And all of those things need to be thought about. What does that cocktail
mm,
of well-being look
mm,
like for me?
mm. I think many of us make, say, whatever you put to your predict tools, we make our own habits an extension of that. And I think it's important to give them as much credibility, because if someone's 1 or 2% survival benefit on an endocrine therapy is there, we know we can reduce our risks by regular exercise.
Yeah.
Not by exactly how much for the person, but you can give yourself a big old tick. We know by reducing or ditching the alcohol, again, we know that is a risk factor, alcohol, isn't it? For every person.
Yeah.
We know processed meat is a risk factor, or smoking, or like you said, obesity. And so we do know we can add layers of risk reductions on top of the treatments you give us. And I think this is what the empowerment piece can be for us. This is
Yeah.
what I can do every day to support myself. And I think sometimes we want to be encouraged to do those
Yeah.
things as patients
Because
as well.
and I that's really important, because if you can't do those things, if you can't exercise because I'm making your joints incredibly sore with letrozole for 1% advantage, I need to figure out whether that's worth it with you.
Mm, mm,
Because if you are having an experience of low mood such that you can't get out of the house or get to the gym or whatever it is because of a consequence, then we have to talk about how we balance those things up,
mm,
because they are likely to be as important as each other, particularly if your risk advantage is small. If you
mm,
are willing to do something else that reduces your risk, you might be better off with that. And if I make that impossible for you because of the treatment I give you, that's maybe not a good trade-off.
mm, mm. Yeah. Someone just said the predictor was shown to them in quite a cold and harsh manner following her own breast cancer surgery. And she was worried today would be very triggering to see it again. But actually, she's found it very empowering. It shows her how far she has come. So well
Okay.
done, you.
Good, brilliant. That's really, and to remember that I hate this idea, cancer is a journey and all that. I mean, that may be helpful for you, it may not be helpful for you. I'm not, personally, I'm not sure that as a narrative, it's a helpful one to peddle, but it is a process.
Yeah.
There is a process, and there are things that happen along the way, and you will feel differently. And I often say this, but you'll feel differently in 3 years' time. You just don't know that yet because you haven't got there. This will be a bump in the road at some point, but today it's your everything. In 3 years' time, it's not going to feel the same.
Mm, mm. Kay said she doesn't want her breast clinicians thinking that she's not trying. She's had radiotherapy and she's really struggling on tamoxifen and she feels horrific. And there is that feeling, right, that we think the fault is with us or we're not trying hard enough.
Yeah. Uh, uh,
Mm,
it is, I say to my patients, this is my fault. That's the way, this is the way you feel is my fault. It's the drug that I am giving you that is making you feel this way. This is nothing to do, because people will come in and they'll say, what can I do? And people, maybe people come in chemotherapy and their blood counts are low or whatever it is, and they'll say, what can I do? And I go, this is not your responsibility. And it's not your responsibility. You are being given something that is creating a set of circumstances. Are there things that you might be able to do to help yourself? Absolutely. But ultimately, if you're having side effects, that's my problem, not yours.
Mm, mm. And Claire, what do you do with all of the DCIS patients? There are a few in the chat here,
Yeah.
and so are they like the triple negative patients? The predict tool doesn't support them in their treatment
So
decision?
I think if you click DCIS, I can't remember what happens in Predict when you click DCIS, because but they very rarely come to an oncologist. Normally they will be dealt with by a surgeon with some experience, but yes, they will often be offered tamoxifen. And of course, there may be the people who may be BRCA positive who may be offered treatment prophylactically, for example.
Yeah.
And again, having a think about, is this worth it for me? Do I have enough information to weigh up the risk for me personally?
And someone does say they have a big advantage of staying on their tamoxifen, and they'd like some tips on managing symptoms like aching joints, hot flushes, weight gain. Please check out our YouTube. I'm going to put the YouTube link there.
Yeah, you've
We've
done a
got
lot of those things before, Dani, about how to manage a lot of that. Yes, so there are different ways of doing it. You can split doses, you can do alternate days, you can change the time of day that you take your medicine. There are other medicines that you can add in on top that might help. There are lifestyle things that might be able to help to manage those. You've done a lot of that before, so if you've been able to link to some of the things that suggest. And sometimes all of that, sometimes it'll work and sometimes they won't. And to a certain degree, it's a little bit of trying it and see.
And Claire, before I read you a couple of lovely messages, for people that have had secondary breast cancer or metastatic breast cancer, this is a very different conversation.
Yes.
Yeah.
Yes. Well, we can do that separately, Dani, for those people if you wish. But that's a different conversation again, because some of the treatments they might be offered might require them. So if we think about any of the ciclibs, so palbociclib or so Ibrance or abemaciclib or any of the other treatments require you to be on a hormone treatment for those treatments to work. So there's a different set of a different conversation needs to happen there. And of
Yeah.
course, the stakes are higher. We're talking about a different set of circumstances.
Mm.
We will know whether your treatment is working because we will be monitoring you to see whether your cancer is improving. And if it is, then the side effects are worth it. If it's not, then it's time to change to something else. That's a different conversation.
Yeah. Kate said, this is a fantastic explanation of the tool. Thank you, Claire. It was only discussed with her in a hurry at the time of diagnosis, but feel it is something that now, a couple of years into the therapy,
Yeah.
I feel I would be able to have a very much better, calmer and more informed discussion about it. And I'm so passionate about talking about that time. Takes so long to make treatment decisions, even to think, shall I start a new exercise regime? It takes forever long to find a new gym or a new class or something that suits you, right? And our expectation is we should know at the drop of a hat always.
And I think that's also something that's really important that I say to people at this stage of at the point where they're starting, is that what I see is people are diagnosed, they have whatever their treatment pathway is, whatever that is, they fall off the end and they expect to be the same person with the same level of fitness and the same that they were here. And that's just never going to be true. If you were an elite athlete and you had this time off, you wouldn't expect to pick up where you left off. So coming off the end, at the time when you're starting your hormone treatment, getting into it, your body has all of this stuff to recover from. So you need a graded approach. You need to be realistic about what you can do right now. But what I see is people go, I'm not the same as I was before, and they get frustrated and they stop trying. And they think that their breast cancer has taken it all away from them. You've just got to bridge that gap. You've got to think about a graded way of getting back to where you can get back to where you were before, just not overnight. You have to start a graded exercise program. You need to be realistic about what you can do in the gym, and you need to build it up slowly. I say to people, okay, you go out for a walk to the shops today. Tomorrow, you go out to walk for the shops in the next 2 minutes. And the next, you have to build back up to it, because I think often people's expectations of my cancer is finished, I should be back to normal. That might be our own internal expectations or expectations of family members, or the ways that people behave towards you as if you should just have gone back to normal, are unrealistic. So there's also something at that point around being realistic about what you're really like now and what you might have in the future.
And that's so frustrating. when
Yeah.
we can't do what we used to do, and when our brain doesn't work the way it did, and when our energy levels are not there, it's really frustrating. Someone said this is the first time she actually heard about Predict and that this exists. This morning I felt hopeless, and now I feel like there is hope. So that's absolutely wonderful. How long will it take for side effects to go if someone
Okay.
wants to persevere? Is there a little bit of a timeline?
So again, it depends who you are and what you're on. In general terms, I would say to people, give the treatments 4 to 6 months to see. If at 6 months you're exactly the same as you were in month one, then that's maybe the way it's going to be. But for some people, it will wear off over time. The easiest way to know is to have a 4-week holiday. Well, depending on what you're on. If you're on tamoxifen, you need essentially a 12-week holiday off the drug to know what you're like, because it's got a very long half-life. If you're on letrozole or anastrozole or exemestane, 4 to 6 weeks off the drug will give you a reasonably good idea about whether it's the drug that's the problem. And because of what I've just said, which is people have become deconditioned over time, sometimes they stop the drug and realize it's nothing to do with the drug. It's how they, what has happened as a consequence of their chemotherapy or their recovery, or they've not quite recovered or whatever else. They might stop the drug and feel no different. They might have been perimenopausal. I've given them chemotherapy and I've knocked off their ovaries, and now they're genuinely menopausal. So they would have
Yeah.
been having this experience whether they were on the medicine or not. So there's lots of ways of trying to disentangle, is this the drug or is it something else? And if it's something else, what can we do to support that?
Because someone is asking this because they have concerns that in the meantime they might actually lose their job or have to go sick long term. That's how horrendous
Oh,
her
that's
symptoms are. So she's trying to understand when to stop it so she can hold on to her job. So
I
that's
would, if I was in that, if it was that life changing and that life affecting in a negative way, if that was somebody who was coming to me, I would be saying, I think you should have 4 to 6 weeks off and see how you feel. If people feel dramatically better, then it's worth a change. If I'm going to guess that that person's on an aromatase inhibitor, not tamoxifen. That would be my guess. I might be wrong about that. If they were on an aromatase inhibitor, I would take them off for 4 to 6 weeks and I might try a different type. So there are three mains: anastrozole, letrozole, and exemestane. I would switch them to something else and see, because actually sometimes that of itself can be enough. So it depends what you've been starting. Different centres have their different favourites and whatever else, but there are other options there of switching them around. And another option is if you've been on an aromatase inhibitor and you really haven't struggled, then tamoxifen might be an option. And sometimes that's depending on what your symptoms are. Tamoxifen has a slightly different side effect profile to the others.
And so the drug holiday you just mentioned, do you have data on a 6-week drug holiday is safe, for example, or an 8-week?
Well,
Is
I
that
think
what is that just
so that's a difficult, no, we don't, is the short
okay.
answer. So people will always say to me, is it safe? And I'll say, well, it's safer than you going away and not taking it for the next 5 years. So again, we have to be, a lot of this is quite pragmatic.
Yeah.
Not as much of this is as directly data driven as you might imagine, because it's individualized. It doesn't, we can't know. I say to people, over the course of a 10-year experience on an AI or an aromatase inhibitor, we are likely to be recommending this to you for 10 years. Having 4 weeks out of that 10 years is unlikely to make a difference.
Welcome to the menopause.
And you will know one way or the other whether it's the drug that's contributing to how you're feeling.
This person was worried about the drug holiday and how long is safe for her. And so again, this goes back to your fear, doesn't it? It's trying to understand what the fear means in numbers or away from numbers. How are you feeling
Yeah, absolutely.
And for those people whose side effects seem to get worse, you just said sometimes side effects get better, but
Yeah.
some people are saying their side effects are getting worse. Is that normal?
They may, yes. So that can happen depending on what your side effects are, and also your mental response to the side effects that you're experiencing. So then we can get into quite a negative cycle of side effects. The more we concentrate on side effects, any experience that we concentrate on our body that we start to feel negatively about becomes amplified. So that makes perfect sense to me. And that's not to say that it's all in your head, but that is how it works. If you have pain and you concentrate on the pain, pain is a wind-up phenomenon. The more you concentrate on it, the more you're going to experience it. The more you experience it, the more you're going to think about it. Da 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 da. So it makes perfect sense why people's symptoms would be getting worse, because their tolerance is falling, their emotional tolerance for putting up with, the resilience is falling. Their mental health might be suffering because so all of that makes perfect sense. So yes, your symptoms might be getting worse. Absolutely.
Okay, lots more questions, but I'm going to blank that question box out now, Claire. I'm going to put into the show notes a link to the podcast. I'm going to put another link or YouTube. So I think people, you just need to go on a little learning journey yourself, because you're all at different. Some of you, I recognize your faces and you've been coming for a long time and you dip in and out, and others are very new to our community here. So look through the titles, listen, watch, and go on that learning journey yourself. For the people that have specific questions like joint aches, there's a whole episode just on joint aches, and the doctors talk about supplements and exercise and medication. So do listen to those. Lots of lovely thank yous. I'm also going to put the research, our research study in again. I'm hoping I'm going to share all of the lovely survey results with you, Claire, so that when you talk to your medical community, you can quantify what people are experiencing. So many people are telling you, Claire, that this was the first time they've heard information like this, that it was the first time it was brought in such an elegant manner, beautiful words by someone, that they feel more empowered and less scared, although they came worrying a little bit about what they might find out. Thank you so much. This has been amazing. I feel so much less alone. Thank you so much. And a very informative session. So Claire, thank you. I know I've taken far too much of your time.
Not at all.
All the best for you for getting back into work after your holiday.
Thank you, Dani. And if anybody wants to reach out to me, you'll find me I'm all over the internet talking about sex and menopause and cancer and various other things. And
Yeah.
you just Google me, you'll find me.
I hope you found, as you're listening to this or you're watching this conversation, as helpful as the many people that joined us for this live recording. I think there is such a big need to talk about all these things a lot more. I think our treatment appointments during and after cancer treatment are short. We turn up to them, we're often very anxious, and it's scary to talk about those things. So maybe when you had the chance to ask these questions, you weren't ready to have these conversations. And so all of these workshops are here for you to really help us digest and mull over this information and understand what you could do with that information where you're at right now in your treatment, a bit like Claire said, journey. And so I hope it's been a useful conversation. I think Dr. Claire Macaulay is a fantastic oncologist, and I'm so grateful for her time and for explaining all of this in such a beautiful manner to us today. Can I please remind you, fill in that survey, have your say. We want to hear from you. Maybe you had to come off HRT and you were suddenly told, stop your HRT, you're embarking on breast cancer treatment. Or maybe you were never premenopausal and your cancer treatment made you menopausal. We want to hear about your challenges so that we can tell the survey results to the world, to other doctors, to researchers, so that we can improve cancer survivorship for everyone. Thank you, and thank you for being here today.